Well, Bonjour, hello, good morning, everyone. Thank you for joining us for the Native Center for Alcohol Research and Education webinar series. My name is Cole Alec. I am from the Turtle Mountain Band of Chippewa Indians, and I am the new tribal liaison at Partnerships for Native Health, a research program at the Institute for Research and Education to Advance Community Health, also known as IREACH. In this webinar, Dr. Patricia Valverde, Callie Numa, and Riley Witt will give a presentation on transitions to recovery. Next slide. Before Dr. Valverde begins, I'll give a brief overview of Partnerships for Native Health at IREACH and the Native Center for Alcohol Research and Education, or NCARE. Next slide, please. IREACH at Washington State University challenges the status quo and advances community health through partnerships and collaboration. We conduct research with rural, Native, and Latinx populations, health networks, and populations with substance use disorders. Next slide, please. Our IREACH faculty belong to various colleges at Washington State University, and we partner with external collaborators at universities all across the country. The Institute houses 5 primary research programs, which include Partnerships for Native Health. Next slide, please. Partnerships for Native Health conducts community-based research and education to improve health and reduce health disparities among American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. We do this by working with both community and academic partners in community settings. We focus on achieving health equity, community outreach and engagement, and training and education. We have over 60 partners across the country, of which our partners include tribal colleges, Native organizations, tribes, and universities, as well as 7 satellite centers located in Alaska, Colorado, Minnesota, New Mexico, North Carolina, Oklahoma, and Washington. Our program focuses on research topics that are important to the populations we serve. Next slide, please. Within NCARE, our aim is to optimize alcohol intervention research for public health in general, and our Native community partners in particular. We accomplish this goal by collaboratively engaging with research project teams and the pilot projects to conduct research that yields high-quality data while simultaneously meeting the unique needs of our partners. After the conclusion of this webinar, you will be given a chance to provide feedback through an evaluation survey. A recording of the webinar and presentation slides will also be available on our website, ireach.wsu.edu/ncare. At the end of the presentation, there will be time for a Q&A. So please submit your questions using the Q&A box in Zoom. And now I would like to hand it over to our presenters. Miigwech, thank you.
Hi, good morning or good afternoon, everyone. My name is Patricia Valverde, and I am so pleased to present our project Transitions to Recovery to all of you. I'm also very excited to have along with me Callie and Riley. I'm in Colorado at the Colorado School of Public Health, whereas Callie and Riley are in the field in Fairbanks at the Detox Center, and they are part of our study team. Next slide, please. So what we'll cover over the next 45 minutes or so is just give you some ideas of the consumers that we're working with. We'll also explain why there is a need for the use of patient navigation in detox and recovery. We'll describe the study and the components of the study. We'll also discuss the challenges that we've experienced over the past 4 months in implementing this study and our lessons learned, and end with the conclusion. So first, Riley will give you a snapshot of one of our participants. Next slide, please.
Good morning, everyone. I'm Riley in Fairbanks. And so this is sort of a sketch of sort of a compilation of a lot of our consumers picking up on some themes. So, for example, Johnny is a 43-year-old male from rural Alaska, homeless, drinks about 2 liters of vodka a day, suffers from serious health comorbidities like high blood pressure, hepatitis C, depression, anxiety. Because of alcohol use, this consumer has been unable to stay in housing or get treatment for his medical conditions. His social network is mostly the people that he camps with in the woods in Fairbanks. He's currently unable or unwilling and unable to return to his home village for legal or personal reasons, not in touch with his family. But there's also some deep trauma issues, and he wouldn't want to go back there, even if he could. So some themes that we encounter in a lot of our consumers sort of really define our project in a lot of ways. Some of these themes are homelessness, disconnection, so serious health comorbidities, history of trauma, historical trauma, as well as a strong cultural connection, very vibrant non-family communities, and some vibrant family communities, resilience, creativity, the enduring of great difficulties with great good spirits, and as well as dealing with mental health issues without treatment. We encounter a lot of people with very strong faith, and a hopefulness. So sort of there's themes that pop out among all these consumers.
Thank you, Riley. Next slide, please. So let's look at the big picture first and why there is the need, because consumers like the one described by Riley are many. This slide is actually from Ursula Running Bear, who's a co-investigator, and the study is based on extensive research and experience and relationships between Spiro Manson, our principal investigator, and behavioral health centers in Alaska. And so what we know is that even that Alaskan Native people are disproportionately represented in treatment admissions due to alcohol, and that in the interior of the state, alcohol is a leading cause of mortality. So one of the first aims of this study, it was to look at medical data or chart data from a detox center in Fairbanks, and that was conducted by Ursula Running Bear. And what she found was that within a year, 40% of the consumers that went through the detox center were actually readmitted. And then she compared that to the rate of readmission in the general populations across the US, which is 26%, so a considerably higher readmission rate. She then looked at that phase moving from detox to into treatment, and found that only 2% that were of the consumers going through the detox center actually went into treatment within the year. Now, to compare that to the general population transition rate of between 49 and 64%. So what to do about this? How do we make an impact? So Spiro and Ursula and the team decided to focus in on that transition phase from detox to treatment, because the belief is if we can increase that transition rate, then we could also help reduce the readmission rate into detox. So fortunately, with a long-standing relationship with the Fairbanks Native Association, we were able to implement this transition to recovery program. And Callie will now describe FNA and the detox center to you. Next slide.
Hi, this is Callie. So within Fairbanks, through the Fairbanks Native Association, we have a wonderful and somewhat unique continuum of care that starts with our detox center here, Gateway to Recovery. It is providing ASAM level 3.7 WM for withdrawal management, and it is something that is staffed by nurses, CNAs, and a physician's assistant. This provides medical withdrawal for people in Alaska, both Alaska Native and non-natives here. The average length of stay is about 3 days, and the recommended amount for people who are withdrawing from alcohol is somewhere between 2 to 5 days, and then it can go up to 7 to 10 days for people withdrawing from opiates. From 2011 to 2015, approximately 1,200 unique admissions. Next slide, please. So as I was mentioning earlier, there is this wonderful continuum of care, and I moved here from Portland, Oregon, which has a lot of resources, but I've been very impressed by how people can start at detox and go while staying within the same organization from detox to inpatient residential treatment to outpatient to community services. So it's wonderful that we have that opportunity here. Ralph Perdue Center is a 45-day residential treatment program. It has 10 beds. It is for both men and women. They have ASAM level 3.5 and 3.3, and they're working on getting a 3.1 program available. That essentially means that they have services that can be offered at a number of level of hours while people are living there, which is wonderful for our consumers who are experiencing homelessness or an unsupportive recovery living environment. Then they also have outpatient, which they have both intensive outpatient, which is more than 9 hours a week, and level 1 outpatient. It is an 8-week program. They have room for 30 patients. Then we also have Women and Children's Center for Inner Healing. This is a long-term residential treatment program. They want people to stay for at least 4 months. Generally, people stay for about 6 months. And women who are pregnant or women with children up to the age of 7, as well as women who are working with our Office of Children's Services in order to reunite with their families. All of these offer individual psychotherapy, group and family therapy, alcohol, drug education, anger management, and case management. Next slide, please.
All right, thank you, Callie. So as I mentioned, the first aim of this study was to look at the data from the Detox Center, which Dr. Running Bear completed. The second aim was to then adapt some type of intervention to try to impact the rate going from detox into treatment. And what was decided was to use a model of care called patient navigation. So the challenge is, how do you adapt patient navigation into this setting and with this consumer population? So what we decided was that this is a randomized trial. So both arms, the control and the navigation arm, will receive one session of motivational interviewing in order to be able to focus on motivation to enter into treatment regardless of study arm. But then one arm will continue to receive patient navigation, which can include constant assessment of motivation and working on motivation. But the patient navigation primarily is to focus on dealing with the challenges that the consumers might face in entering treatment, and we'll describe that further shortly. Next slide, please. So this figure shows the flow in our study. When a consumer is admitted to Gateway to Recovery, the Detox Center, the clinical staff meets every morning and discusses who's ready to be discharged, but they also look at which consumers are potentially eligible for the study. Then our staff recruits them and consents them and conducts baseline data collection, which includes a number of instruments. From there, they move into the one session of motivational interviewing, and towards the end, the person is randomized to either continue to receive patient navigation for a month, or the MI is concluded and their intervention participation ends there, other than the follow-up data collection. So now we'll discuss the specifics of the MI and the PN component. Next slide.
So with motivational interviewing, this is something that happens after we have administered the surveys. So we have some ideas of things that people might be interested in working on, or areas in their life that are impacted by their substance use. And we begin to build rapport and get a sense of what of the things that we've heard are most important to them, what values are they bringing into this, what are their goals. And we really try to individualize that conversation to those things that we have learned from their perspective. About 10 to 15 minutes in, that's when we do our first set of scales. That is a set of 3 questions we ask at the beginning and at the end, and we let them know, okay, I'm going to ask you this now, and I'm going to ask you this later. So we assess their readiness, importance, and confidence on a scale from 1 to 10. And then when we're hearing that, sometimes people do give the same answer for all three of those, but sometimes people will also give fairly different answers where they feel that it is extremely important, but they don't have confidence or they don't think that they're ready. And we ask this within starting treatment in the next 30 days. And we move from there. And sometimes people are very low motivation. Sometimes people are ambivalent, and sometimes people are really high motivation. And we structure the rest of the motivational interviewing session based on that. If they are low motivation, then we might be exploring what the impact of their substance use has had on their life, what values that they have that they think might impact their interest in treatment. If they're ambivalent, then we're looking at that sort of classic motivational interview style of, okay, on the one hand this, but on the other hand that. And then if they are high motivation, sometimes it is looking into, okay, what have you looked into already, using some of those elicit, provide, elicit skills of, okay, so you've heard this about this program, what else do you need to do, sort of style. And then at the end, we ask the skills again: readiness, importance, and confidence. Next slide, please. From there, we randomize, as Patty was talking about. And then if they are in motivational interviewing only arm, then we recap their action plan that was created at the end and provide them a list of resources, and usually an affirmation of, you know, you've shown these strengths, and, you know, I'm sorry I can't work with you further, but, you know, wishing you all the best. And then for people who are in the patient navigation arm, that is, we try to get one session in before they discharge. So during that patient navigation session, there hasn't been a lot of time for some of these things to happen. It's usually a review of the action plan and maybe starting things like applications if they are high motivation. Then they discharge, and for the next 30 days, we try to keep in contact with them either in person or over the phone. We shoot for about once a week. So what happens once they're out is we, again, kind of gather their consent, not in a formal sense, but just make sure that they are continuing to understand what this is and what we are doing, discussing the study and what our role is. And then from there, looking at, you know, what's changed since we last spoke, and provide some encouragement or support for any challenges that they've encountered, just again, kind of warming that relationship back up with the rapport. Then assessing treatment rulers, again, that readiness, importance, and confidence, and seeing how that's changed. Motivation can fluctuate so much, even minute to minute. So maybe they were low motivation or high motivation when we were talking to them before, but something has changed. They've talked to their family or their friends and either received support for or against what their plans are. So that can look really different. And then we review progress made towards their goals. What have you filled out? Who have you talked to? What things have you shored up to help you transition to treatment? And then we use those motivational interviewing skills to enhance motivation, affirm their strengths, and recognize their change talk. Then sometimes that's making a new action plan based on what they've already achieved, or based on maybe a shifting in their goals or what they think the best plan moving forward would be. And then we reassess the rulers and make a plan for the next follow-up appointment. Next slide, please. So to illustrate this, I'm going to provide a story of a participant that I worked with about how sometimes building that trust can really take a while. This participant is an Alaska Native man who was enrolled in July. He was experiencing homelessness, and his primary substance was alcohol, but he had, it's sort of difficult to tell how much consent he had around starting meth, but that was something that had that he's been at detox for a number of years, and they had not seen that, and then they were starting to see that and starting to see it increase. So really frightening for him. And he was someone who had previously been not really engaging in treatment even when he had been there, and doing things that was really burning bridges. And he was assessed at a SAM level 3.7, which is where someone needs fairly intensive support that also includes medical and psychiatric in his case. So we're going to have him go to the only 3.7 option, and there was some difficulty in communication where we were hearing that he was accepted, but then he got there and he talked about some legal issues, and they let us know, like, we can't accept him. And so then we had to get him back up from Anchorage, where the only 3.7 option is, which is about an hour flight from Fairbanks. And yeah, so that took a lot of rebuilding trust with him, because, you know, we told him, okay, you're going to go down there, and we'd really talked it up and gotten his motivation up to go there, and talked about ways in which this was going to be a good option for him, and he was excited, and then it didn't work. And then we eventually started to rebuild that trust again, and he applied to several other options, but they were options that he had already had experiences with, and that plus his legal history led to him being rejected from all of them. It was a lot of heartache, and helping him understand why this was happening and working to keep his motivation up was really challenging. And he had escalating suicidal ideation and escalating meth use. I was honestly very worried about him. We had an application into the last option in the state when I received a call from the treatment option that is closest to us and within our continuum of care here at FNA. And she was talking to me about another client and asked if there was anything else she could do for me. And I sort of half jokingly said, hey, would you reconsider this guy? I know that he didn't work out before, but, you know, I would love to help set up that connection. I've been building this rapport with him. We've been working together. And she said yes, and let him come over for an intake. And I went over with him, and there were a couple things that, you know, there were hesitations, but, you know, just kind of using that rapport that we had been building and using that information that, and just the strength and drawing on the strength and pointing out the strength that he'd shown by working on this so hard and going through all these disappointments, and thinking about, like, why are you working so hard on this? What values are going into this? The intake coordinator said she could tell a huge difference in how willing he was to engage with treatment. And that felt, I joke that that's our most important data point. Obviously, they're all weighted the same, but in my heart, that's like the one that is weighted the most. Next slide, please. This one's Riley's slide.
Yep. So some examples of activities that we will do as part of patient navigation. So patient navigation can look different for every consumer, and sort of what the approach we're taking is so focused on meeting the consumer where they're at and hearing their story, hearing their needs and desires and wants and hopes for themselves. So really what we do is we facilitate them in enacting that and help them, you know, create a plan, an action plan, and then take steps. So, you know, it can be different what we do for each consumer. So for some consumers, we help them schedule assessments. We remind them, you know, when the assessments are. We will accompany them, you know, if they're nervous or you know, have other barriers. We help them identify different resources in the community and try and stay in contact with people who, you know, potentially could be good resources for a consumer, and then to make those connections between people and resources. sometimes we're just moral support. You know, we're an ear to listen, someone that they can reach out to when they need to talk. And we're not, you know, we're not trained counselors, we're not trained, you know, healthcare providers, but we connect them to resources. So we are part of that support network. We also are sort of I think of a lot of the MI skills. So, you know, in our asking of open-ended questions, in our affirming the goodness we see in each, you know, and the strengths we see in each consumer, and especially in reflections and summaries, we're sort of providing the consumers with a mirror through which to see themselves differently and to reimagine, you know, their situation and their barriers. So we will help them, you know, sort of define what's holding them back and come up with definitions of, you know, this is what we have to overcome, or this, you know, this is the issue. And then finally, sort of with the patient navigation, we're always making action plans, and then we're revisiting our action plans and revising our action plans. It's sort of amazing how effective that can be for helping people to move forward and take steps in directions towards recovery. Next slide, please. So as an example of some things we do, so this is sort of another imaginary consumer drawn from different consumers. So this consumer is a 64-year-old female, lives in Fairbanks, experiencing homelessness, and has some potential neurocognitive difficulties, history of stroke and falls, and has been to treatment multiple times, but not engaged, and will just sort of sit there, listen, not participate, and then sort of just every time we see them here, we'll, you know, we can make a plan, and then the consumer will sort of wander out the door and forget about the plan, and we won't be able to follow up because a lot of people won't have reliable means of communication. A lot of people are on foot and have little, you know, routes or places where they are. But so part of our work is finding safe spaces to approach and connect with people, or for each consumer, it's sort of a riddle of figuring out how will we reconnect with this person, you know, on their terms, in a way that's comfortable for them and you know, safe for us, and then to follow up with them and just sort of remind them of, you know, the conversation we had during the motivational interview and the goals we set, and just sort of check in and say, you know, where are you now? What can we do in this moment to help? And so, like, one of the consumers that sort of is sparks this case study in my mind was you know, somebody that, you know, would come back pretty much weekly. And so although we weren't able to you know, call them on the phone or send them an email, they would come back to us every week. And so we could, in that sense, have very reliable follow-up. And it was amazing how that relationship sort of built and created, you know, trust, you know, where they'd immediately recognize and remember and sort of have this touchstone, and then also, you know, doing the appropriate ROIs and being able to forge a connection with family to sort of breathe some life into these other relationships, and eventually get sort of a coalition of people working for this consumer, involving, you know, going to, you know, the Medicaid office and sitting for long hours, you know, and helping them be patient with the system, and then eventually, you know, taking them to the airport, transitioning, you know, putting them on a flight to Anchorage, and then having them be lost in the airport in Anchorage, and, you know, talking to the person there who's looking for them, and then realize that, oh, they just, you know, we're taking a long time getting out of the airport to the gate, and then eventually, you know, finding each other and making their way into treatment. So sort of our role is just to be there and be attentive, responsive, kind, and above all, listen to people and what they need and want.
Next slide, please.
So this is sort of the case study here. So we focus on rapport, explore intrinsic motivations. So come up with the reasons that this person has for change. For a lot of our consumers, those are health, aging, trauma that they've seen or experienced, or then advocate. So if a bridge, as Callie described, if a bridge has been burnt, to sort of ask the question, as an outsider, why did this happen, and sort of give the opportunity for a reset. We do arranging travel, so we do very, mundane things like arranging Medicaid travel or arranging transportation, doing research on housing options, or for one consumer, we helped her access. So she had a walker, but she was very old, and we helped her access a walker with a little seat. So when she was walking around downtown, she could actually, when she got tired, sit down for a few minutes. And it's like little things, but I think our approach is that these little things will snowball into, just some positive possibilities, as well as facilitate the communication. So just sort of ask the questions and, get people talking. And so the patient navigator isn't, we're not necessarily part of the communication, but we're just sort of, and we are in a sense, but we're also we're not guiding it, we're facilitating it, we're allowing change to happen. And then we do these warm handoffs, which are great, and just sort of supporting people and letting people know that somebody cares and is paying attention.
Next slide.
So something that we are frequently navigating with our consumers here is chronic homelessness. And this is something that can be very cyclical. People will have poor physical and or mental health, and that makes it hard to find stable housing, and they will find themselves experiencing homelessness, whether that is literally outside. At the last point in time count for Fairbanks, we had about 300 people who are year-round homeless, and that point in time count happens in January, where it can get to -40 or colder here. And so we have that homelessness, and there is an amount of substance abuse that can kind of help in coping with that, but can also contribute to the cyclical nature of this. It can hurt people's physical and mental health, and it can also make it difficult to obtain housing. In a SAMHSA survey, 2/3 of people reported that addiction was a factor in their homelessness. And in a longitudinal study on homeless women, at baseline, almost half of the women had used a stimulant in the past 6 months. And then 6 months after the baseline survey, 14% of the women who had not used stimulants at the start of the study had started to use them. And this is a particularly acute concern because using a stimulant while also drinking is a leading cause of death among homeless and unstably housed women. So poor physical and mental health can also be a barrier to treatment, with treatment centers rejecting people who present too high of a risk due to physical or mental health concerns. And homelessness exacerbates those conditions. The average lifespan of a person experiencing chronic homelessness is about 20 years less than average. Additional factors that make this difficult that we have discussed throughout this presentation is not having a phone, belongings being constantly stolen, and that it is difficult to prioritize getting treatment over getting housing, but then it's also really hard to get housing when you are struggling with this substance use and mental health disorders, and that can also lead to a lot of this bridge burning that we are seeing. So it is a really difficult cycle, and it all contributes to everything else. Next slide, please.
Thank you, Callie and Riley, for really giving a robust description of the type of work that you both have been doing with the consumers and the challenges that are faced by the participants in our study. So now you're all probably wondering, okay, what have we seen so far? What have we been able to accomplish? We just started about 4 months ago recruiting participants. So over the past 4 months, we have been able to recruit 56 people out of 168 admissions. We're tracking reasons for ineligibility, so you can see the list. And a good portion of the people that are coming through are already in the study, in which case we are able to reconsent them and they continue either receiving another round of motivational interviewing or motivational interviewing with navigation. There's also a good group of people who leave against medical advice, and so they're not eligible because they may not receive their behavioral assessment or go through the different phases of detox that are necessary in order to be eligible for our study. We have, as you heard in these different case studies, we have individuals who have even more complex comorbidities, whether it's medical or psychological, and are not eligible. We also have a group of people who are in some kind of treatment but relapse. Since when they leave detox, they may move right back into that treatment setting. They're not eligible. And a couple discharged to jail. Next slide, please. So what have we been able to accomplish? Next. Overall, about 25% of our participants have moved into treatment. Now remember, that's 25% to, originally we saw 2% in Dr. Running Bear's original evaluation of the data. So, you know, we are showing some great progress. Next. Our window of entering into treatment that we're primarily focused on is within 30 days, and we are still seeing about 16% of our enrollees entering into treatment. Next. However, we are seeing 14%, even though they enroll into treatment, return to detox. So there's definitely some area of growth over the next couple of years. Next. So what have been the challenges? One major challenge has been operationalizing our eligibility criteria. As you can imagine, with the complexity of situations of our consumers, there's lots of gray area, so making refinements to make sure that we're both not enrolling people who really should not be in our study for a variety of reasons, or missing out on consumers who really could benefit from our study. So, you know, really figuring out the eligibility criteria and developing guidelines around that. Another major issue that is very common with patient navigation projects is adding new staff and new roles to an existing structure. So with that, it takes a lot of communication and clarifying what is the specific role of the patient navigator, where does it overlap and duplicate any detox staff roles, and how do we make sure that we're not duplicating, instead we're in a supportive role where needed, and then taking on roles or activities that are not done by the detox staff. And in addition, this is very common, you know, monitoring scope creep so that the patient navigator isn't taking on additional activities that really do not fit within both the role in our study. We've also found that transportation is a major issue, and the need for the navigator to be able to help coordinate and arrange and support the transportation of our consumers, particularly the homeless consumers. We would love to be able to compensate our participants for visiting with the navigator. However, that is not local practice, and so we're unable to do so with many good reasons. So having to both overcome those challenges of meeting regularly with the consumer, and also just the setting in a detox center. The patients there don't feel well at all. So figuring out the right timing and the right setting for meeting with them so that both to discuss the study and then once enrolled, really having a good, strong conversation around the goals and values related to treatment. Next. So what have we learned? So as you heard in that study flow, the navigators and the study staff do a baseline survey, which is a very structured interview, but then shift into motivational interviewing, which is more open-ended question and trying to really understand where the person is at. So that takes some practice and some skills, and so learning how to transition into these different components of the study. We also have understood that everyone wants a navigator, and we see that a lot in other navigator programs where staff would really like to see a particular consumer receive that additional support. However, in order to prove or see if navigation actually does provide an added benefit, we do have to randomize. So making sure that people understand why we're doing it this way and supporting it. One wonderful lesson learned is that our navigator does not have a behavioral background, health background, and so she has gone through training on motivational interviewing, been able to practice extensively with Callie, who is in graduate school for counseling, and then is now, we also have an MI coach. And so our navigator is able to utilize motivational interviewing at a very competent level. So, and that is consistent with the literature with training, lots of practice and coaching. MI can be done by non-behavioral health staff. We've also learned how to be very open to the fact that even when a consumer says no multiple times, that there's always that opportunity when their motivation level changes and they may say yes. So being very open to possibilities with this population is important. Next slide. So in conclusion, we feel very proud and thrilled at being able to very successfully implement a patient navigator program using motivational interviewing with this population that has very complex needs. We also have realized and have learned that we need a site champion, which we have, so that our program is able to be seen by the staff as a benefit and important. It also requires constant communication with the host site and lots of clarity and communication around the navigation role, and really making sure that we're identifying and utilizing the appropriate resources for our patient population. And lastly, but probably most importantly, many of us are not Alaskan natives and Native Alaskans, and so we have to continuously learn about the culture and the experiences of our patient population. We have to show humility and be very aware of the variety of historical trauma experiences that our consumers have, and really being patient-centered in our work, which is why the use of motivational interviewing and patient navigation are wonderful strategies to use, especially with cross-cultural communication. Last slide, please. So finally, I would like to thank Spiro Manson, who's the principal investigator of this project, Ursula running there, who is a co-investigator, but she developed this project and implemented it. And Erin Poole, who's our study manager. And with that, we will conclude and open it up for questions.
Thank you very much. This is Gladys Rowe. I'm a research coordinator at NCARE. I invite you to type your questions into the Zoom box there. And what I'll do is read them out and have the team respond to your questions. We have about 14 minutes. For the questions that we are not able to get to, I invite you to email me afterwards and I can make the connection to the study team. So the very first question that we have is, how long is a long-term treatment?
Callie, would you like to respond, or Riley?
Sure, I can. So the long-term treatment, I'm seeing in the chat box you said for the moms. That one is our Women and Children's Center for Inner Healing. And that one is between 4 months to 6 months, sometimes a bit longer, sometimes a bit shorter, but they do try to get them to stay there for at least 4 months. A lot of the other treatment options that we are sending people to, most of them are 30 to 45 days, and then we do have treatment options in Alaska that go up to 1 year long.
Great. I have another question here. The slide that stated 56 individuals were recruited to date for the study, with 63 already in the study not eligible. Could you clarify that?
Those are readmissions. So we have 56 individuals, and then the 63 is people being counted multiple times because they have readmitted.
Thank you. I have a comment here for you. Well done, lots of capitals and an exclamation mark. As a PhD level professional who has had family members with exactly this compendium of problems, your program is conducting research on exactly what is needed to help these patients and care providers.
Thank you. This is Patty. I just wanted to say that, you know, one thing that we took very seriously is finding the right study team and figuring out what the qualities and the experiences that we were looking for in a patient navigator. And I just can't tell you how thrilled we are about our study team right now and their ability to help us kind of test out a new intervention. I keep telling them that we're kind of learning as we go, because patient navigation, at least in the literature, is not widely used in detox and the transition to treatment phase. You know, there are plenty of peer support type programs that we can look to, but it has been a wonderful experience with these 2 women. And we also have a new navigator who just started. So we're very excited.
Wonderful. Well, thank you so very much for taking the time to make this presentation today. Oh, I have one more question that popped up. Is Ursula Running Bear's publication available? Do you have a reference or a citation?
So my understanding is that it is in process. And I'm not sure if she has created an abstract for some conferences, but we can certainly ask her and respond to you offline.
I have another question. You mentioned that staff want everyone to get the intervention. How do you communicate to staff the importance of randomization in assessing the efficacy of the intervention?
Kelly or Riley?
I would say that a lot of the staff does have at least some training in, like, they're either have nursing experience or social work experience. And so they do often have training in research, and they understand that research is, does often, and the gold standard of research is the randomized controlled. So I think that there is usually a logical side that they do understand that. I think that sometimes it is just the emotional side that does make that hard, where and I feel that too sometimes, where it's like, oh man, I really wish this person could help. And we try to point out that if we can show this, then hopefully this is a program that can continue where everyone will be receiving these services, if we can show that it is effective. Does that make sense?
And this is Riley, and I would just add that we have the same challenge communicating to consumers that we're trying to recruit what is randomization. And I find that it's not that, difficult. People can understand, a 50-50 chance of being in this group or that group. And so it's sort of, but there is a challenge of explaining clinical research in, terms that are understandable to everyone. And I believe we've gotten better at that as time has gone on.
So another question here. Conceptually, how does a navigator differ from case management? This reminds me of a CRA program in some ways.
Hi, this is Patricia. I'll try to take that one. That's a wonderful question, and I get that a lot. I work in patient navigation nationally. And so patient navigation, although many of the activities overlap with case management, the intervention or the role of the patient navigator is really founded on the idea of reducing health disparities and identifying those barriers and moving the person, assisting them to remove those barriers to access or to continue in some type of treatment. Patient navigation is often conducted by lay people. So, there's plenty of nurse navigators, but there's also a strong population of non-clinical or non-licensed navigators. And so it also helps to remove the need for either a clinical person to conduct those types of activities that we described. And also it allows for focusing on kind of the non-clinical, like the social determinants of health challenges that are faced by a patient population. But we can't deny there's plenty of overlap between patient navigation and case management or care coordination. So I probably made you more confused. But this is definitely, one thing that we're always talking about nationally and with different projects is how do you kind of differentiate between the patient navigator and maybe you have a case manager at the same setting.
I have another comment here. So the navigators are addressing the social determinants. It's important to include as active ingredients of this intervention. Few interventions are available at that level.
Yeah, very true. And especially given what you saw for our consumer population, Often there are other more urgent matters than in their mind than going into treatment. So we're constantly talking about housing and transportation. It may include food. So how do we work on those types of issues in addition to supporting them to move towards treatment? So it's a kind of a constant, issue that we're looking at and discussing. And Riley, you may want to add some more.
Yeah, I guess just that our addressing of the social determinants, like I think of that a lot as advocacy, and taking some of the benefits I've had in my life and just using them to the advantage of another person in helping their amplifying their voice. So yeah, I think that really is a good way of describing it.
And before we finish, I just wanted to mention the person that did write about the case management. I'd be very happy to continue the conversation offline and show some of the information that we use to try to differentiate the two. And this is Patricia.
Great, so we'll wrap it up there. Thank you everyone for attending the webinar. The webinar will be posted on our website afterwards, as was mentioned by Cole. Thank you to the presenters. We really appreciate you spending the time sharing about this really important work that you're doing. Have a wonderful day, everyone.